Welcome back to the new section on the classification of the types of diabetes mellitus. Understanding about the classification, the different types of diabetes mellitus is really important because this is the one that's going to, first of all, answer the question of why these many types of diabetes mellitus is existing in the first place. And at the same time, the understanding is the one that's going to give a sound idea about why you are treating a specific type of diabetes with a specific treatment. And that's the one that's going to translate into proper patient care and successful clinical outcomes with regards to the hyperglycemia and diabetes mellitus. So let us start with the basics that initially we had only two different types of diabetes mellitus, type 1 and type 2 diabetes mellitus. Later on our understanding has expanded and we have so many different heterogeneous group of patients right now. We have different types of type 1 diabetes mellitus patients and there are many types which are considered as overlaps between type 1 and type 2. And we have monogenic forms of diabetes in the form of MODY and neonatal diabetes. We have gestational diabetes, pancreatic diabetes, drug-induced diabetes, endocrinologic diabetes, syndrome-associated diabetes, lipodystrophy form of diabetes, defects in insulin action. So we have a whole lot of spectrum of diabetes mellitus as of now. So let us start with the beginning where we had only two different types of diabetes and our understanding is just type 1 and type 2 diabetes mellitus. Let us start with that and let us slowly build up the types of diabetes mellitus in a great depth and detail. So I'm going to draw two circles to facilitate your understanding. Obviously, you would have guessed what I'm talking about. Yes, I'm talking about a type 1 and a type 2 diabetes mellitus where your understanding will start from the basics. So we knew that type 1 diabetes mellitus is absolutely autoimmune in nature. And initially, it starts with the cell-mediated immunity, which boosts the development of antibodies from the beta cells. And later on, the antibody-mediated destruction of the beta cells will happen. But initially, even though the cell-mediated immunity is the most important as far as type 1 autoimmune-mediated diabetes is concerned. So anyways, our basic understanding says that this patient will have antibodies. And at the same time, because there is destruction of the beta cells, the beta cell number will drastically drop down and the patients will start developing insulin deficiency. So what are the features of insulin deficiency? This is called insulinopenic symptoms. Of course, the patient will be having weight loss and they will look lean and underweight because insulin deficiency is a catabolic state. We have discussed in the previous videos itself innumerable number of times. And at the same time, these patients are prone for development of diabetic ketosis. In fact, majority of the type 1 diabetes mellitus patients, first presentations itself will be a diabetic ketosis only. And at least, even though they do not present with diabetic ketosis, over time they have a high risk of developing recurrent diabetic ketosis without insulin treatment. And that's also one reason why this diabetes is also referred to as an insulin-dependent diabetes mellitus. What do you mean by that? Which means insulin is required for survival of these patients. Without insulin, they do not survive and they die. And what about type 2 diabetes mellitus patients? Type 2 diabetes mellitus patients will not have any autoimmunity in the sense like they don't have any cell-mediated or antibody-mediated immunity. So the antibodies will be negative. And most important problem as far as type 2 diabetes mellitus is concerned is they are insulin resistant and it's a lifestyle related disease. We know that insulin resistance is the major problem here. And the patients tends to be obese and at least in the early part of the disease, they have a very, very less chance of developing a diabetic ketosis because they are not insulinopenic. In fact, in the early stages, they will be hyperinsulinemic because of the resistance created by the obesity. Of course, they are non-insulin dependent diabetes mellitus because insulin is not required for their survival and you just need that glycemic correction in the setting of type 2 diabetes mellitus like lifestyle modifications, weight loss and probably treating with some oral drugs like metformin or sulfonylurea is going to correct the glycemic status. And later on, we start understanding about a principle called disposition index. Disposition index basically depends on the insulin secretion versus the insulin sensitivity, that is insulin action is what we are talking about. So if a patient who is having a normal insulin sensitivity and a normal insulin secretion will have a normal disposition index and they don't have any problems like diabetes mellitus like most of you and me. And a patient who is having a reduced insulin secretion but a heightened insulin sensitivity because the body tends to adapt to this low insulin secretion by increasing the insulin sensitivity. And in this condition as well, the disposition index will be normal. But you can clearly note the fact that this patient is having a low insulin secretion, but they will have a normal glycemic control because of the heightened insulin sensitivity as an adaptive response. And this is what is going to result in a state called pre-diabetes type 1. where the glycemic control will be very good, and they might still go for stress hyperglycemia in the setting of surgery, sepsis, or any infection, or in the setting of administration of corticosteroid. They might go for hyperglycemia, but overall their basal glycemic control will be normal. That's what we refer to as a pre-diabetic state. Over time, what happens is your insulin secretion drops to a great extent, and your insulin sensitivity also drops a little bit and becomes normal, where this is the time where the disposition index becomes abnormal and the patient ends up with a overt type 1 diabetes mellitus. So this is a clearly proven hypothesis, and one thing you can note is the fact that there is a small decline in the insulin sensitivity over the period of time, and that is possibly to be one of the main reasons why these patients who are initially having a normal disposition index and had a pre-diabetes are converting into an overt type 1 diabetes. And which means insulin resistance still play a little bit of role in the development of overt type 1 diabetes mellitus. So that is the reason there should be some overlap between type 1 and type 2 diabetes mellitus patients. And at the same time, consider type 2 diabetes mellitus where insulin sensitivity is going down. To compensate for that, body is trying to produce a hyperinsulinemic response. That's why the beta cells try to produce more insulin, and that's why the insulin levels are going to be more in the earlier stage at least, and this will result in a normal disposition index, and this is going to result in a state of pre-diabetes type 2 where the glycemic control will be okay, except for the stressful states like surgery, infection, sepsis, administration of corticosteroids where they can go for hyperglycemia, but apart from that, the overall glycemic control will be okay in this regards. So that's what we refer to as a pre-diabetes type 2. Over time, the insulin secretion becomes normal or decreased, where the insulin sensitivity goes down even worse in this setting because of continuing obesity and poor lifestyle. So this will clearly result in abnormal disposition index where the patient tends to develop an overt type 2 diabetes mellitus where the basal insulin levels itself is not sufficient to overcome the insulin resistance and produce a good glycemic control, where the patient will end up with a frank hyperglycemia and osmotic symptoms in overt type 2 diabetes mellitus. So what you have to understand is the fact that even in type 2 diabetes mellitus patients, initially there was a hyperinsulinemic response. Later on, it's very clear that the insulin production decreases a bit, either it's becoming normal or decreasing over a period of time, which means insulin deficiency still plays a little bit of role in the setting of a type 2 diabetes mellitus development as well, which means there is a small overlap which I can draw that is happening between a type 1 diabetes mellitus and type 2 diabetes mellitus, especially in the setting of insulin deficiency and insulin resistance, where a patient with type 1 diabetes mellitus can have a little bit of insulin resistance, where the patient with type 2 diabetes mellitus can have a little bit of insulin deficiency as well. So which is the major thing is what is going to be the problem. In type 1 diabetes mellitus, insulin deficiency is going to be the prominent feature, and it's going to happen at a much early stage compared to that of insulin resistance, which is going to happen a little bit later. Whereas in type 2 diabetes mellitus, the beginning thing itself is insulin resistance and obesity. Later on, they can proceed towards insulin deficiency once the beta cells get exhausted over a period of time, and the pathophysiology will tell you even more detail, so which you'll be seeing in a subsequent minutes. So now we started understanding that there were some heterogeneous group of patients who didn't fit into type 1 as well as type 2 diabetes mellitus. So let me put a third circle. So where these patients did have antibodies, which means that suggests the autoimmune background, and these patients did not have that much insulin deficiency as we expect. So which means these patients were not insulin dependent. So they are non-insulin dependent, at least in the early stages to start with. But these patients had antibodies with them. So which means it's a mixture of, like, what do you think? It's a type 1 diabetes mellitus and type 2 diabetes mellitus. And in the early 1980s and 1990s, we started understanding this kind of heterogeneous group of patients do exist, where they were having antibodies positive in their blood and body, and there is some evidence of ongoing beta cell destruction as well. But they are clearly non-insulin dependent, at least in the early stages, which means insulin was not required for survival, at least in the early stages of the disease. And these patients, initially they were calling them as type 1.5 diabetes mellitus because they were in between type 1 and type 2 diabetes mellitus. Later on, we have started giving the name called LADA, that is latent autoimmune diabetes in adults. And here, how can you understand is the fact that the autoimmunity is not that great in this setting to produce faster destruction of beta cells, which means autoimmunity is happening slowly over a period of time, because these patients are usually adult patients and they tend to have variable degrees of insulin resistance as well. At the same time, their BMI is variable as well, which means they are not clearly insulinopenic typically in the first place. So they will not typically present with diabetic ketoacidosis, and their incidence of TK is highly variable, but definitely lesser than compared to that of type 1 diabetes mellitus. And at the same time, their BMI is also quite variable because they have varying degrees of insulin resistance because they are moving towards adulthood over a period of time. And because autoimmunity is slow in these patients, they do not develop insulin deficiency in a faster rate. So they are somewhere in between type 1 and type 2. So this is what we refer to as a type 1.5 diabetes mellitus. And in the early to mid 1990s, they found out another heterogeneous group of people who did not come under type 1 as well as type 2 diabetes mellitus, which means they did not have any evidence of autoimmunity going on, which means they don't have any antibodies, but they did have a poor beta cell reserve and insulin deficiency, in fact, to start with, which means these patients had a very high chance of developing DK. In fact, many of them presented with diabetic ketosis, even though the BMI is variable in this regards because many of them tend to be an adult patient. And because of that, they'll be having varying degrees of insulin resistance. Because of the same, they might be having a normal or even an increased BMI. Because these patients are insulin deficient, generally they tend to have a lower BMI because insulin deficiency is a catabolic state as we know it. And without insulin, they will develop and they will surely develop diabetic ketoacidosis, and that's why we are going to put under them as insulin dependent diabetes mellitus. So now this is a very confusing picture because these patients do not have antibodies, but they are insulin dependent. So these patients, they don't know what to call it because you already have 1, 2 and 1.5. So they called it by a different name called atypical diabetes or flatbush diabetes, but current name has changed to type 1B diabetes, which we'll be discussing subsequently. So now let us see how you're going to call this. So classic autoimmune type 1 diabetes, where you get this insulin dependent diabetes mellitus in the early age group, that is in the childhood or juvenile age group, is what we refer to as a classic type 1A diabetes, where you have antibody positivity and there will be insulin dependency. And those patients who are non-insulin dependent to start with for a variable period, at least by 6 months as per the criteria, but it can be variable up to 6 years. To start with, they are not insulin dependent, but they still have evidence of autoimmunity, were called as LADA, latent autoimmune diabetes in adults, where it's considered to be a variant of type 1A, or it's sometimes some people consider as an adult onset type 1A diabetes, or a variant of type 1A is what we refer to as a LADA, where the autoimmunity is not so strong and it happens over a long period of time, and the destruction of the beta cells is slow and steady over a long period of time. And these patients who presented with insulin deficiency and dependency, but they did not have any evidence of autoimmunity, were called as type 1B diabetes mellitus. And those patients who did not have any evidence of insulin dependency to start with, and they are frankly insulin resistant, all the features of metabolic syndrome might be there or once upon a time would have been there, and at the same time they did not show any evidence of autoimmunity, were called as type 2 diabetes mellitus. And now to summarize, what are the basis of all this classification? Let me write type 1A, type 1B, LADA, that is latent autoimmune diabetes in adults, and type 2 diabetes mellitus, and see what are the differentiating points. First one, what about the beta cell mass? Beta cell mass is terribly declined in patients with type 1A and type 1B diabetes mellitus. That is the reason why they do not secrete any insulin, and that's the reason why they are insulin deficient and dependent as well. Whereas in LADA, a reasonable amount of beta cells will be there at the time of diagnosis, and in type 2 diabetes mellitus also there will be reasonable amount of beta cells that will be present at the time of diagnosis. And what about insulin deficiency? Insulin deficiency is a key feature in the setting of type 1A diabetes and type 1B diabetes, whereas insulin deficiency is not a key feature of LADA to start with, and insulin deficiency is not a key feature of type 2 diabetes mellitus to start with. And what about insulin resistance? Insulin resistance is the most important feature as far as type 2 diabetes mellitus is concerned, which is not a very important feature as far as the classic type 1 diabetes mellitus is concerned. Whereas in type 1B diabetes and in LADA, the amount of insulin resistance is variable because majority of them will be adulthood patients, so they can be having variable degrees of insulin resistance. And what about the body mass index? Typically, type 1A diabetes patients tend to have a low body mass index because of the insulin deficiency, whereas type 2 diabetes mellitus patients tend to have a higher body mass index because of higher incidence of metabolic syndrome and obesity, whereas type 1B and LADA patients tend to have a variable body mass index, which means typically they tend to be lean, all right, because of the insulin deficiency, but highly variable depending on the coexistent insulin resistance, whereas LADA patients tend to have a little bit of normal or obese phenotype, but it's highly variable. They can be lean as well, so you cannot predict all these things. And what about the age of onset? Typically type 1A, that autoimmune type 1 diabetes mellitus, tends to happen in the children or juvenile age group, classically in the 10 to 25 year age group. That's where you get the type 1 diabetes mellitus, classic autoimmune type. And type 2 diabetes mellitus you can get anytime post-puberty, which means currently we are seeing a lot of adolescents with type 2 diabetes mellitus because of the very terrible lifestyle practices and severe obesity in those age group because of the televisions and the video games. And type 1B diabetes and LADA tends to be variable, but predominantly they tend to be happening in adults. Majority of times they tend to be happening in adults. And what about the possible therapy? Of course, they are insulin dependent and they need insulin. And type 1B, of course, they need insulin for their survival, and that's why they are insulin dependent for that matters. But whereas, to start with, they are not insulin dependent, at least to start with. And it takes almost 6 months to 6 years, where minimum you have to be non-insulin dependent for 6 months to call it as a LADA. That's the diagnostic criteria. So they can be non-insulin dependent for a variable period of 6 months to 6 years. Then only they might become insulin dependent, or they might continue with their non-insulin dependency. Whereas typically type 2 diabetes mellitus is going to be non-insulin dependent for a long period of time, which means for type 2 diabetes mellitus, insulin is not needed for their survival. And what about the antibodies? Antibodies tends to be positive in the setting of type 1A diabetes, tend to be negative in the setting of type 1B, positive in the setting of LADA, and at the same time negative in the setting of your classic type 2 diabetes mellitus. So these are the basis of our current classification of type 1A, 1B, LADA as well as type 2 diabetes mellitus. But the problem is our traditional understanding in the first and second year. Whatever basic common subjects you take, whether it could be a physiology or a biochemistry or a pathology, they tend to tell one important thing, that type 1 diabetes mellitus patients tend to develop diabetic ketosis and type 2 diabetes mellitus patients will not develop diabetic ketosis. And it's absolutely wrong. And we know currently that there are a huge number of type 2 diabetes mellitus patients who present with DKA. In fact, their first presentation itself can be diabetic ketosis. So those patients who are presenting with diabetic ketosis to your casualty or OPD, but they did not have any past diagnosis of diabetes mellitus, we are going to call by a common terminology called as ketosis prone diabetes. But whether what category they belong to, whether 1A or 1B or LADA or type 2, we have no idea right now, but we are going to call them as ketosis prone diabetes for all those patients who present with diabetic ketosis, but they do not have a prior diagnosis of diabetes mellitus. So depending on the autoimmunity and depending on the beta cell function, they can be classified into 4 different categories. So I'm going to write a small table in the form of category, and what could be the status, like in the form of autoimmune status and beta cell function, and what could be the current nomenclature for the same, and what could be the insulin requirement, whether it is lifelong or whether it is needed or whether it's unlikely, we are going to classify. So first category we are talking is about KPD1A, that is ketosis prone diabetes type 1A, where the status will be autoimmunity positive, which means antibodies will be positive, and they will not be having any beta cell mass, which means the beta cell mass will be below a certain value, but they will not be able to produce any C-peptide at all in the first place. We are talking about the basics now. Later on, once we start discussing about the type 1A diabetes, we know that beta cell mass will be okay in the early stages, and later on it will be depleted dramatically, resulting in over type 1 diabetes mellitus. So right now understand, type 1A is classically described as no beta cell mass at all. There is no beta cells. And the current nomenclature we are going to call it as a type 1A diabetes mellitus, and insulin requirements is yes, definitely lifelong. And we have a ketosis prone diabetes type 1B, where you do not have an autoimmunity, but at the same time you do not have any beta cell mass as well. These patients will be called as type 1B patients, and once again their insulin requirement will be lifelong. because they are insulin dependent and they are insulin deficient, and they will not be having any meaningful production of insulin in their body. And we have another type of diabetes, that is KPD type 2A, that is ketosis prone diabetes type 2A, where the patients will be exhibiting features of autoimmunity, but at the same time they'll be having preserved beta cell mass, at least to start with. These patients are the ones we are currently calling it as LAD, latent autoimmune diabetes in adults, and insulin requirement is possible. We cannot fully rule out the insulin requirement, or we cannot fully tell that these patients will be needing insulin requirement as well. It is highly variable, so I'm writing possible. That is what we refer to as latent autoimmune diabetes in adults. And finally, we have the final type of diabetes, that is KPD type 2B, where you don't have autoimmunity. At the same time, to start with, you have a much preserved beta cell mass. So these patients are the ones currently we are going to call it as type 2 diabetes mellitus, and insulin requirement is unlikely in these patients, which means insulin as a sole therapy and as a life-saving therapy is not the case in the setting of type 2 diabetes mellitus patients, which means insulin is not needed for survival of type 2 diabetes mellitus patients, at least to start with. Of course, these patients will be needing insulin during the episode of diabetic ketoacidosis, and you're going to treat these patients with insulin. And let us assume the diabetic ketoacidosis has resolved. And now my $1 million question will be to answer that whether these patients will be needing insulin even after the resolution of DK or not. It's a very difficult question to answer, but the answers are coming right now. So I hope you understand the question. These patients will be receiving insulin therapy because they have presented with diabetic ketoacidosis with no prior diagnosis of diabetes. And now the DK has resolved because of your efficient therapy, all right. Now whether to continue with insulin or not, or you will switch on to some oral drugs, or you will continue both, or you will not give anything and send the patient home. What's your idea? Of course, you cannot take a chance by discontinuing insulin, and you have to continue with insulin, because you have to assume that these patients are insulin dependent no matter what, and you have to continue insulin, and because the patient or the healthcare setting cannot afford to have one more attack of diabetic ketoacidosis if you discontinue insulin. So continue insulin and titrate to achieve glycemic control. Once you have achieved the glycemic control, maintain that for at least 2 to 4 weeks and make the patient happy for some time. Maintain for at least 2 to 4 weeks. Antibodies are not helpful in this scenario. I'll tell you why. Because of two reasons. One reason I'll be telling later. Then second reason is your technical incompetency, because many of the times antibodies will take a long time to reach you, or at least it will not be available in your center. So don't rely on the antibodies as of now. Just achieve glycemic control with the insulin alone and maintain that for 2 to 4 weeks. And now my goal is to find out whether this patient is insulin dependent or non-insulin dependent. How can you find out? Reduce the insulin dose to 50% of what is needed to achieve the glycemic control. So once you have reduced the insulin dose, check for the ketone bodies. If the ketosis reappears, so we're not going towards the ketoacidosis. To develop acidosis, you need a large amount of insulin deficiency with increase in counter-regulatory hormones. But here you are reducing only 50%. Still the insulin is going on in the patient. But once you reduce to 50%, this small decline in insulin will result in ketosis if the patient is insulin dependent. So that is the definition of insulin dependent diabetes mellitus. So if the ketosis reappears. If the ketosis does not reappear, which means even after reducing the insulin dose to 50% of what is needed for the glycemic control, if the ketosis does not reappear and the ketosis is not there in the patient, then these patients will be termed as non-insulin dependent diabetes mellitus. So to know whether the patient is insulin dependent or non-insulin dependent, you don't need any antibody testing or any extravagant testing. All you need is your clinical understanding and your ketone bodies. That's all. So now to further classify this patient as type 1A or type 1B, you need to know the antibody status. If antibodies are positive, I'll be calling it as type 1A diabetes. If antibodies are negative, I'll be calling it as type 1B diabetes mellitus. But for the therapeutic reasons, for clinical reasons, I don't think antibodies are needed in the first place. And understand the fact that patients who are destined to be diagnosed as insulin-dependent diabetes mellitus, you have to clearly tell these patients that you have to continue insulin therapy. You cannot afford to discontinue insulin therapy, and you have to in fact go to the previous dose of insulin, not the 50% dose. Continue insulin therapy in these patients, and also counsel them that this insulin therapy is going to be mostly lifelong. because it's insulin-dependent diabetes mellitus. If ketosis is not developing, that it is NIDDM. So in that setting, you have to attempt to discontinue insulin for the matters. And how will you discontinue insulin? So look for the glycemic control, because now we have given only 50% of the insulin dose that have been used to achieve the glycemic control previously. So now once you have given 50% of the dose, if the glycemic control is still good, now you can just discontinue the insulin and observe the patient. So if the glycemic control is poor after reducing the insulin dose to 50%, in this setting, you have to switch to some oral drugs. And depending on whether glycemic control is good or not, further insulin may be required. But here the most important feature is the fact that these patients will be needing oral drugs rather than insulin. And you can attempt to discontinue insulin. So this group of patients, once you have discontinued insulin and once you are observing, once again, if the glycemic control becomes poor over a period of time, you can switch to oral drugs like metformin or sulfonylureas or DP4 inhibitors. If the glycemic control is good, then you can continue the observation. You don't need anything else. Clear? So this is how you establish a diagnosis of insulin dependent as well as non-insulin dependent diabetes mellitus for that matters. Clear? And the usual oral drugs that we start after discontinuing insulin is very likely to be metformin and probably a DP4 inhibitor, which is having highest evidence, like sitagliptin or linagliptin. And we do have other different types of diabetes mellitus which does not fit into type 1 as well as type 2 diabetes mellitus. So that is why aptly this can be put as another round, which will be coming as other types of diabetes mellitus. Usually risk of decay is very less in these patients, and at the same time, it will not fit under type 1 as well as type 2 diabetes. What are these and what are the classification? The first group of patients will be coming under type 3A diabetes, and these are monogenic forms of diabetes, which means they will be due to single gene mutations. And monogenic forms of diabetes can be either a neonatal diabetes, which we'll be discussing subsequently, or it could be a maturity onset diabetes in the young, otherwise referred to as MODY. And you have multiple different types of MODY, which we'll be discussing subsequently, but remember the fact that MODY is the most common form of monogenic diabetes in the world. And especially MODY type 3 is going to be the most common type of MODY, and MODY alone contributes to 2 to 5% of the entire spectrum of diabetes. So it's also very important, which we'll be discussing subsequently. And we have a type 3B diabetes where there's going to be problem in the insulin action. So defects in insulin action. Defects in insulin action can be further subclassified into either receptor level problem or post-receptor level problem, which we'll be discussing subsequently. And we have a type 3C diabetes, which is also referred to as pancreatic diabetes, but these are due to problems in the exocrine pancreas. We're talking about exocrine, not endocrine pancreas, which means it could be chronic pancreatitis, cystic fibrosis, fibrocalculous pancreatitis. Many disorders are there, which we'll be discussing subsequently. And we have a type 3D diabetes mellitus, or otherwise referred to as endocrine diabetes, or certain endocrinopathies apart from problems in insulin can result in diabetes mellitus, like glucagonoma can produce diabetes, Cushing syndrome can produce diabetes, hyperthyroidism itself can produce diabetes, pheochromocytoma can produce diabetes mellitus. So somatostatinoma can produce diabetes. So certain endocrinopathies can result in diabetes, again which we'll be seeing subsequently. And we have a type 3E diabetes, typically drug-induced diabetes like corticosteroids, then levothyroxine in excess dose, then we have thiazide diuretics, then calcium inhibitors, especially tacrolimus. All these things can produce diabetes, which will be coming under drug-induced diabetes mellitus. Then type 3G diabetes, which will be usually due to some uncommon problems or immune-mediated problems, immune-mediated diabetes. Uncommon or immune-mediated diabetes, for example, Stiffman syndrome, the details of which I'll tell you in some time. Then we have a type 3F diabetes mellitus, which are typically due to infections like rubella or cytomegalovirus. And finally, we have type 3H of diabetes, which is nothing but syndromic forms of diabetes, which happens in Down syndrome, myotonic dystrophy, Friedreich's ataxia, with the details of which we'll be discussing subsequently again, syndromic forms of diabetes. So we have type 3A, B, C, D, E, F, G, and H. So all these things is very important to understand for exams. So each and everything we'll be discussing separately. And we have another form of diabetes that is coming under a different circle, that is gestational diabetes mellitus. Once again, the pathophysiology of gestational diabetes mellitus alone we'll be discussing in this particular video, but the actual problem and the treatment and the clinical features have to be discussed separately under a different heading called diabetes in pregnancy. More than that, there is one wrong name called as type 3 diabetes mellitus. You can argue that these are the type 3 diabetes, but no. There is a separate type 3 alone, not 3A, 3B, 3C or 3D like that. There is a separate type 3 diabetes which is said to happen in Alzheimer's disease. But I don't know how much the nomenclature is correct, but what they are supposed to tell from this understanding is the fact that Alzheimer's disease patients tend to have insulin resistance in the brain. Because of insulin resistance in the brain, reduced glucose uptake by certain neurons in the brain, they are postulating that it results in Alzheimer's disease. That is why Alzheimer's disease and resulting dementia is thought to be due to a type of diabetes called type 3 diabetes, which is nothing but insulin resistance in the central nervous system. Having understood about the classification of diabetes mellitus, we have to move on and see about the pathophysiology of the type 1 diabetes mellitus. Let's discuss this graph after some time, which is shown in the image right now. But before that, let us understand what you mean by a type 1 diabetes mellitus. Understand the fact that type 1 diabetes mellitus means beta cell destruction and resultant insulin deficiency. But people might argue that beta cell destruction is seen even in type 2 diabetes mellitus. But understand, in type 2 diabetes mellitus, beta cell exhaustion is due to chronic hyperglycemia and glucotoxicity, which happens over a long period of time. It might take even decades to completely exhaust the beta cell reserve. But in type 1 diabetes mellitus, it happens much faster in a span of weeks to months to years. It will not take decades. And subsequently, these patients will have insulin deficiency. Once again, compared to type 2 diabetes mellitus, they go for the insulinopenic stage at a much faster pace compared to type 2 diabetes mellitus. And they do not have any evidence of insulin resistance, or they might have a very mild insulin resistance compared to that of the type 2 diabetes mellitus patients. So you have to first understand the differences between type 2 and type 1. So once you know what you mean by type 1 diabetes mellitus, now it's better to see the sub-classification of type 1 diabetes mellitus that is based on the antibodies, that is the autoimmunity that is present in the background. And second is the genetic markers for that autoimmunity, because to develop some antibodies and autoimmunity, you need certain genetic background for that, and that is what we refer to as a genetic marker of autoimmunity. Depending on whether it is there or not, you can sub-classify further. If it is there, then it will be an autoimmune type 1 diabetes mellitus. If it is not there, it is a non-autoimmune type 1 diabetes mellitus. Non-autoimmune type 1 diabetes mellitus is also referred to as type 1B diabetes mellitus. As we know already, these patients will be insulin dependent, which means without insulin they will develop ketosis and subsequent diabetic ketosis and they will die, which means insulin is needed for lifelong. And majority of these guys will be adults. And that is the reason why amount of insulin resistance and BMI might be little variable, but overall because of insulinopenic problem that is happening in the body, the patients generally tend to be a little bit leaner than the general population because insulin deficiency is a catabolic state. But again, BMI and insulin resistance will be variable in the setting of type 1B diabetes mellitus because majority of them are adults. Autoimmune type 1 diabetes mellitus can be further subclassified depending on insulin independency. How long they are living independent of insulin. If the insulin independency is for less than 6 months, which means most of the times there will be no insulin independency. That's the idea. Most of the times they will not be insulin independent from the time of diagnosis itself. In that setting, will be diagnosed as a type 1A autoimmune diabetes. It's a classic type 1 diabetes autoimmune form. It's a type 1A diabetes. Suppose if the insulin independency lasts for at least 6 months or more, that's a very important diagnostic criteria for LADA, then this disease will be called as latent autoimmune diabetes in adults. So where the definition clearly tells the patient should be insulin independent, which means they will be maintained either without insulin or with oral drugs at least for 6 months or more. That is what we refer to as a latent autoimmune diabetes in adults. So we know type 1A diabetes is the classic autoimmune type 1 diabetes, which happens in children or in the juvenile age group, but very classically in the juvenile age group. Classic age is 10 to 25 years of age. But please understand the fact, any child with less than 10 years plus diabetes mellitus is equal to type 1 diabetes mellitus unless proved otherwise. Even though some rare possibilities you have to exclude, like for example, mitochondrial diabetes, where the patient will be having deafness and myopathy, that will be a clue. And syndromic diabetes, where the patient will have syndromic appearance, that will be a clue. Or the patient might be having neonatal diabetes, where the diagnosis will be made within first 6 months of life. Don't confuse this 6 months with that 6 months. So 6 months of life, that is neonatal diabetes. Anyways, these patients, we know they are absolutely insulin dependent from the beginning itself, and they will be insulin independent by definition, within 6 months only. They cannot be insulin dependent beyond 6 months. And most of the time, from the time of diagnosis itself, they'll be insulin dependent only, which means insulin is needed for their survival and their life. And LADA is a very tricky diagnosis, that is latent autoimmune diabetes in adults, because it is something, a combination of type 1 and type 2. That's why it's also referred to as a type 1.5 diabetes. And there are a lot of similarities and dissimilarities with type 1 and type 2. So let us write type 1 diabetes and type 2 diabetes here, and let me write the similarities and dissimilarities here. What is the similarity with type 1? Of course, antibodies are positive. That's the biggest similarity, and that's going to be the biggest similarity with type 2 diabetes mellitus as well. So antibody positivity, autoimmune background. Dissimilarity with type 1 means they are non-insulin dependent to start with at the beginning. That's the biggest dissimilarity, and it's maintained at least for more than 6 months. And that's the similarity with type 2, because even type 2 will be non-insulin dependent at the beginning, of course. At the beginning, and they will persist at least beyond 6 months. That's the diagnostic criteria. Non-insulin dependency at least for 6 months or more. Apart from that, there are some dissimilarities with type 2 diabetes mellitus. So what are the dissimilarities with type 2 diabetes mellitus apart from having autoimmune background? Number one, they'll be having a faster secretory deterioration of the beta cells. Remember, the secretory deterioration and the beta cell exhaustion in type 2 diabetes mellitus takes place over years, and after only decades you will have that secretory deterioration in case of type 2 diabetes mellitus. But there will be a faster deterioration in the setting of LADA. And there will be an early sulfonylurea failure in the setting of LADA, whereas typically type 2 diabetes mellitus patients tend to respond to sulfonylurea for a considerably longer period of time. So you have so much of differences with type 2 diabetes mellitus and LADA, and so much of similarities with type 2 diabetes mellitus as well, and similarly you have similarities with type 1 diabetes mellitus and dissimilarities with type 1 diabetes mellitus as well. That is why the diagnosis of LADA is a little tricky. And remember the fact that most of the patients with LADA also will be adults. That's why you have to be very careful. Remember, even adults with diabetes, a few subset of patients, like 5 to 10% of the patients may be having type 1 diabetes mellitus, either in the form of a type 1B diabetes mellitus or a LADA. So you have to be careful. 5 to 10% of adults with diabetes may have a type 1 diabetes, which is typically either due to autoimmunity or may not be due to autoimmunity, but they might be insulin deficient. So be careful about that. And I've told you about the diagnostic criteria for diagnosis of diabetes, different types of type 1 diabetes mellitus. Now let us move on to the graph. And of course, to develop autoimmunity, you need to have a genetic background. And coupled to this genetic background, definitely you need to have an environmental trigger to produce the autoimmunity. In this case, we are talking about the autoimmune type 1 diabetes mellitus. So we are going to discuss about what are the genetic background, and at the same time what are going to be the environmental triggers that's going to result in development of autoimmune type 1 diabetes mellitus. So this is the same as for many autoimmune disorders in practice. So what are the genetic background that makes the individual susceptible to development of autoimmune type 1 diabetes? First, of course, we are going to talk about the HLA based genes. And the two HLA genes that are very important are the HLA DR3 and DR4, which confers the maximum risk as far as genetic susceptibility is concerned. Suppose if somebody asks if I am possessing HLA DR3 or if you are possessing HLA DR3, DR4, what is the percentage risk that is conferred for the development of autoimmune type 1 diabetes mellitus. It's approximately 5%, and that's a very, very important number to know for exams. So that's a population risk. Overall risk is 5%. And there are some non-HLA genes that can also confer risk of development of autoimmune type 1 diabetes mellitus, like for example, the insulin gene, especially the variable nucleotide tandem repeats, if it's present within the insulin gene, that confers a risk of development of autoimmune type 1 diabetes mellitus. This VNTR can be located in other genes as well, where presence in other genes will impart autoimmune disorders specific to that particular gene, but in this case, it's the insulin gene that's the one that's going to harbor this VNTR. If that's the case, they are going to develop autoimmune type 1 diabetes mellitus. And CTLA4 gene is really, really important, especially the polymorphisms of CTLA4 gene. Why? Because this is not only going to result in autoimmune type 1 diabetes mellitus, this is going to impart risk of multiple other autoimmune disorders, including vitiligo, autoimmune thyroiditis. For example, it could be a hypothyroid autoimmune disorder like Hashimoto's thyroid disorder. It could be a hyperthyroid disorder like Graves' disease as well, which is also autoimmune in nature. Or it could be imparting a polyglandular syndrome, especially the polyglandular syndrome type 2, which is polygenic in inheritance, because type 1 diabetes is also polygenic inheritance. Or polyglandular syndrome type 2 is also polygenic inheritance, which you have studied already in a great depth and detail in the beginning of the endocrinology itself. But anyways, fine. So we know the genetic risk factors, and you also have to understand one more stat, that almost 90% of type 1 diabetes patients will have at least one genetic susceptibility factor present in them. At least one genetic risk factor will be present in more than at least 90% of the type 1 diabetes mellitus individuals. Okay. Now, having known about the genetic background, let us see some of the important points on the environmental triggers. The most important being the cow's milk has been consistently proven, along with the entry of gluten in the diet of the child can trigger the development of autoimmunity, or alterations in the gut microbiome can result in the development of autoimmunity. And at the same time, certain viruses like Coxsackie B viruses can also trigger the development of autoimmunity. And there are some environmental factors which are thought to be protective against the development of autoimmunity, like for example, breast milk, that is the mother's milk, can actually be protective, and at the same time, vitamin D is supposed to be protective in majority of the trials against the development of autoimmunity and autoimmune type 1 diabetes mellitus. And once we know that we have certain genetic and environmental risk factors for development of autoimmunity, now we have to know the process of development of autoimmunity. So for that, we need to know the most important component, and the triggering the component, or the one that kickstarts the autoimmunity, is the cell-mediated immunity. Especially the T cell mediated destruction is the most important as far as autoimmune type 1 diabetes mellitus is concerned. And T cell is the one, once it gets activated, it's going to trigger the B cells to produce humoral immunity as well. And once they produce humoral immunity, they are going to generate antibodies. That's going to be the final nail in the coffin, and they're going to kill the beta cells, resulting in beta cell destruction and insulin deficiency. And there are some antibodies that are important. You have to know the antigens, and the prevalence of these antibodies is also important. The number one antibody is the islet cell antibody, called as anti-islet cell antibody. And the antigen is, of course, the islet cells. It's relatively non-specific antibody, but still seen in approximately 70 to 90% of the individuals. And second antibody, of course, is the famous GADA. That's called glutamic acid decarboxylase antibody, and the antigen, of course, is going to be the glutamic acid decarboxylase, especially the 65 kilodalton isoform of the glutamic acid decarboxylase. That's why this antibody is also referred to as anti-GAD65 antibody. And this is supposed to be a very important antibody because the prevalence is 80%, very common, and it's very specific for autoimmune type 1 diabetes mellitus as well. And this is really, really important in the setting of LADA, that is latent autoimmune diabetes in adults, because this antibody tends to persist for a longer period of time, even in adulthood. That's why, especially when you're talking about a type 1 diabetes mellitus in adults, especially in the setting of LADA, this GAD antibody becomes the most important antibody of all. And what is the function of GAD? We know the function of GAD is very simple. They are going to produce GABA, but how this is going to cause trouble in the setting of autoimmune type 1 diabetes mellitus is not clearly known, but still, we know GAD is going to produce GABA. And we have a third type of antibody called insulin autoantibody. As the name suggests, the antigen is going to be the insulin. Prevalence is approximately 70%, specific antibody. And we have an antibody called IA2A, that's called insulinoma-associated tyrosine phosphatase domain 2A. Typically, the antibody will be directed against an antigen called tyrosine phosphatase, which is called as an insulinoma-associated antigen. And this tyrosine phosphatase is going to function as a regulator of the secretory granule system. So the insulin will be stored in secretory granules in the beta cells. This is the one that's going to recruit the secretory granules, tyrosine phosphatase. That's why this is important. Antibodies against this will result in autoimmune type 1 diabetes mellitus, and the prevalence is approximately 55 to 75%. And the last antibody is going to be another transmembrane protein called as zinc transporter 8, against which you will develop an antibody called zinc transporter 8 antibody, and the prevalence is unknown. Again, a very specific antibody. And now we have a new antibody called IA2B that also does a very similar function. But we have totally 6 antibodies, out of which 5 are very important. IA2B is very new. In that, the islet cell antibody is supposed to be non-specific, remaining all are specific antibodies, of which the most important is going to be the GADA, that is anti-GAD65 antibody. And remember the fact that whenever you are testing for antibodies, at least test 2 to 3 antibodies. Don't test only one antibody, otherwise you will tend to miss the bus. So at least try to test for 2 to 3 antibodies minimum. Now, after knowing about different antibodies and the mechanisms of autoimmunity, let us see the graph finally. So in the graph, the BCM stands for the beta cell mass, the FPG stands for the fasting blood glucose. Initially, there will be certain genes that are fighting with each other. One is giving the susceptibility, one is giving the resistance against destruction. So there will be interactions between genes that impart susceptibility as well as resistance. But ultimately, patients who are having the genetic factors which I have told already, like DR3, DR4, will be having susceptibility more than resistance. So they're going to get that immune tolerance and breakage of immune tolerance over a period of time, which results in destruction of the beta cells. So environmental triggers also play a vital role. So initial phase of life, there will be these interactions between environment, the genetic susceptibility factors, and anyways, this is something called a priming for destruction in the future. And once the immune tolerance breaks down, your beta cell destruction will start. And the beta cell is going to reduce in number, and it will result in a frank insulin deficiency in the child. But you can see that despite having insulin deficiency and beta cell numbers are decreasing, the fasting blood glucose and the baseline blood glucose tends to be maintained in the normal range. So why is that so? That's due to multiple reasons, but the most important reason is the fact that these patients tend to counteract the insulin deficiency by increasing the insulin sensitivity. So during this phase, there will be increased insulin sensitivity. That is the reason why, despite having low insulin, they are able to maintain a normal baseline blood glucose range, which is evident by the normal fasting blood glucose. And this phase is what we refer to as a pre-diabetes phase. And don't think that pre-diabetes phase means they will always have a normal blood glucose. Why it is called pre-diabetes? Because they tend to have a glucose intolerance, which means after giving a glucose load, they might not be able to maintain the glucose in a normal range, because insulin sensitivity can fight only up to a certain extent. When you are giving too much load of glucose, these counter-regulatory mechanisms break down, and they might result in hyperglycemia. And second, they might encounter something called a stress hyperglycemia, which means during stressful situations, this defense mechanisms break down and they start developing hyperglycemia, like during sepsis, infection, during surgery, or when the patient is receiving corticosteroids, where in this situation, the counter-regulatory hormones will become too much, thereby increasing the glucose levels, but insulin levels and the increased insulin sensitivity will not be able to cope up at this point of time, resulting in elevations of blood glucose causing stress hyperglycemia, which means during the time of pre-diabetes itself, they might have stress hyperglycemia and glucose intolerance. So, but under normal circumstances, the overall baseline blood glucose will be maintained in the normal range because of the increased insulin sensitivity. And of course, there will be a point where you are going to have further fall in the insulin secretion, which will be resulting in an increase in the fasting blood glucose and the baseline blood glucose. Why is that happens? This increase in the fasting blood glucose and the baseline blood glucose happens due to two reasons. One reason, there will be critically low beta cell mass, which means insulin levels will go below a certain limit where you can no longer cope up with the maintenance of normoglycemia despite having higher insulin sensitivity, doesn't matter. And second reason, the child might have reduced insulin sensitivity because it's not only the beta cell mass that is declining over time, it's all the child who's growing over a period of time. And growth means they'll be exposed to multiple different foods, and especially the lifestyle is not good. And if the child grows obese and eating a lot of junk food, that may result in a little bit of blunting of that insulin sensitivity that is already there in the child. That might result in development of overt type 1 diabetes mellitus. So whenever the baseline blood glucose starts rising, that is called as a overt type 1 diabetes mellitus. Overt type 1 diabetes mellitus is divided into two stages further. The first phase of overt type 1 diabetes mellitus, we tend to call it as a honeymoon phase. And first of all, why we call it as an honeymoon phase is the first question, and second question is what is the importance of the honeymoon phase? Both are important. And why you call it as an honeymoon phase, and what do you mean by honeymoon phase? Honeymoon phase is the period where there will be critically low beta cell mass, which will not be able to maintain the normoglycemic state, but still there will be some amount of insulin and some amount of C-peptide that is there in the individual. Because of that, there are some importance with regards to the honeymoon phase. The first importance of the honeymoon phase is the fact that your insulin requirements will be low, because these children will be diagnosed as type 1 diabetes mellitus because they come with osmotic symptoms and hyperglycemia like polyuria, polydipsia, polyphagia. All these symptoms will be there in the child. So you will be checking and you will be finding out that this child is having a type 1 diabetes. And once you start with insulin in these children, there is an increased risk of hypoglycemia. And many of the times, if you start with the usual dose, they'll go for higher incidence of hypoglycemia. Because of that, you will be forced to reduce the insulin dose. And sometimes the child might maintain the glycemic status just with 2 doses of regular insulin per day, and which means you will have a very low insulin requirement. Why you are having a very low insulin requirement? Because the exogenous insulin is actually supplemented or given a helping hand by the endogenous insulin secretion, which is still happening. The C-peptide is still positive, still there. This is what we refer to as a honeymoon phase. So increased chance of hypoglycemia after starting insulin should give rise to a thinking in your mind that this child is having a honeymoon phase probably. Or typically, to be honest, if there is a detectable C-peptide, that is what we call it as a honeymoon phase, which happens in the earlier phase. And the second importance is the fact that this honeymoon phase is absolutely temporary. It is not at all permanent. You have to be very clear about that. And which means at one point of time, whether sooner or later, this child is going to develop a frank and complete insulin deficiency and loss of C-peptide. So that is the case here. So there is this next phase of overt type 1 diabetes where there will be absolutely no C-peptide. And at this point, definitely the insulin requirement is going to increase in the child. And the incidence of hypoglycemia will fall a little bit. And this temporary nature of this honeymoon period should be definitely educated and definitely should be informed to the parents as well as to the child if possible. Because otherwise there will be miscommunication and they might be thinking that this is the insulin requirement for the child and they won't turn back again to the hospital, and you have to be very clear in communicating that this is only a temporary phase. And this temporary phase is highly variable, which means it can last for 3 months, 4 months, it can last for 10 months, it can last for up to 2-3 years in certain children, but not more than 3 years usually. But that comes to a next importance, that the doctor or the treating physician should attempt to prolong the honeymoon period if possible, which means this is a good period in the child's life of type 1 diabetes mellitus, where the insulin requirement is actually very low and the child can eat whatever he wants to an extent. But at the same time, the doctor has to be very careful in prolonging this honeymoon period as much as possible, like taking measures like giving a good lifestyle modification to the child, reducing the junk eating and giving more balanced diet, so that your insulin sensitivity does not go off, and giving a good physical activity and physical regime so that that will maintain the insulin sensitivity and prolong the honeymoon period for a longer period of time. So there are three importance. One is increase of hypoglycemia, so you have to give reduced insulin dose, which is a blessing in disguise. You'll have a reduced insulin requirement for a variable period of time. And second, it is definitely temporary and it has to be educated. And number three, one has to attempt to prolong the honeymoon phase as much as possible by giving a balanced diet and healthy lifestyle practices. And the graph shows a lot of things, and I've explained in detail about so many things in that particular graph. And now let us see what are going to be the clinical features of type 1 diabetes mellitus. Children with type 1 diabetes mellitus, of course, they are going to present very commonly with osmotic symptoms. You know what are osmotic symptoms? They are nothing but hyperglycemic symptoms due to glycosuria. So they're going to result in polyuria because of glycosuria. At the same time, because of excessive water loss, they will be having polydipsia as well. And number two, they might present with insulinopenic symptoms. Insulinopenic symptoms in the sense they will be having polyphagia, which can happen in insulin resistance as well. Polyphagia is due to poor glycolysis, having poor conversion to ATP without insulin. If there is poor conversion to ATP, there will be increased hunger produced by the hypothalamus, thinking it's energy deficient state, resulting in polyphagia. Or they might have weight loss, growth failure, very, very common insulinopenic symptom, because insulin is required for proper growth. If the insulin is not there, they will result in growth failure. And cachexia, malnutrition. And at the same time, child is prone for development of ketosis as well, because there is no insulin in the child's system. And that is the reason why sometimes the first presentation could be decay in the setting of a type 1 diabetes mellitus. That's why they are highly decay prone. The 50% of the autoimmune type 1 diabetes mellitus, especially the childhood juvenile onset type 1 diabetes mellitus, 50% of the patients present for the first time with diabetic ketoacidosis. That's a very important point. And at the same time, there is a variant of type 1 diabetes mellitus, especially the autoimmune type 1 diabetes mellitus, called as a Mauriac syndrome, which happens in children. Mauriac syndrome is basically a triad where you will have a growth failure in the child, along with delayed puberty, along with moderate to massive hepatomegaly. And these children will definitely have a type 1A diabetes mellitus. The problems in the child is thought to be due to type 1A diabetes mellitus, that is causing the growth failure and all these issues. Plus at the same time, there is a mutation in the PHKG2 gene. This gene is thought to produce one important protein, especially the catalytic unit of the glycogen phosphorylase. Catalytic unit of glycogen phosphorylase gene. Remember, glycogen phosphorylase is very important for the breakdown of glycogen. There are two enzymes that are important for breakdown of glycogen. One is the glycogen phosphorylase, second is the debranching enzyme. Of course, if there is a defect in the glycogen phosphorylase gene, especially the catalytic unit of glycogen phosphorylase enzyme, you are going to result in a poor breakdown of glycogen, and because of glycogen accumulation in the liver, you are going to result in a moderate to massive hepatomegaly as well. Now we have to move on to the pathophysiology of type 2 diabetes mellitus, which is even more complicated than that of the type 1 diabetes mellitus. If you want to tell in one word what is the reason for development of type 2 diabetes mellitus, it's the fat. Fat is the reason for everything. Fat is the reason for development of insulin resistance. Fat is the reason for development of type 2 diabetes mellitus. Fat is the reason for development of atherosclerotic cardiovasculitis, and fat is the reason for development of many other problems like PCOS. So what is the reason for accumulation of fat? There are multiple reasons, including genetic, but the most important being your lifestyle. So type 2 diabetes is basically a lifestyle related problem. One is going to be the diet, which is going to be very poor, composed of more of saturated fats and junk food. So that's going to be the most important reason. And second is going to be the sedentary lifestyle. You are not burning out the fat that is present in your body. So it's basically a lifestyle related problem. How adipocyte can result in development of type 2 diabetes mellitus? Let us see. So initially you have pre-adipocytes to start with, then they'll become mature adipocytes, then they're going to become hypertrophic adipocytes in the setting of poor lifestyle. So let us start with the pre-adipocytes first. which is going to become mature adipocytes, which is going to become hypertrophic adipocytes. Pre-adipocytes does not have any much capacity to store fats, and they have very little, if at all, no capacity to store fat, and they have to become mature adipocytes in order to store fat in a sufficient manner. And conversion to mature adipocyte is a very, very important process, because that is the one that helps in storing the fat, and at the same time, that's the one that prevents the spilling of the fat into the visceral organs, which is the main important reason for development of insulin resistance. And a lot of important factors that help in conversion of this pre-adipocytes to mature adipocytes. Many are there, and among that, the most important is the PPAR gamma, that is peroxisomal proliferatory activity receptor gamma, which is one of the nuclear transcription factors. And once you form a mature adipocyte, and if you take too much of fat, more than what the mature adipocyte can store, the mature adipocyte gets transformed itself to an adipocyte with even more higher capacity called as hypertrophic adipocytes, and this is where your problems are going to start. This hypertrophic adipocytes is going to release a lot of distress signals in the form of adipokines. As I told you, adipocyte is an effective endocrine organ, and they're going to produce a lot of adipokines, especially the inflammatory adipokines, that can recruit inflammatory cells, because it's a distress signal for them, and you are taking too much of fat, more than what the body wants. Especially macrophages is what will be recruited, and once the macrophages are recruited, you are going to result in inflammation within the hypertrophic adipocytes. So let us draw the macrophages over here. So, and you're going to create a lot of inflammation, and of course the macrophages are going to produce TNF alpha and IL-6 as inflammatory mediators, and you will have an evidence of that by having a elevated high sensitive CRP as well. That's why obesity is regarded as an inflammatory state, and the resultant atherosclerotic cardiovascular disease and atherosclerosis is also regarded as a major inflammatory state in the body. And now one of the important effects of this TNF alpha and IL-6 is to block the conversion of pre-adipocytes to mature adipocytes. In a physiological perspective, this is considered as a homeostatic mechanism, because you need not have more and more mature adipocytes, because in this condition, otherwise they will become more hypertrophic adipocytes and you don't want fat in the body. So that's why they are trying to block the pre-adipocyte conversion to mature adipocyte conversion. But the problem is these individuals will be persistently taking more and more fat, and they'll be having too much of bad diet. But if the pre-adipocyte does not become mature adipocyte, then where will the excess fat will store if you take after this point? So this excess fat either has to be somehow pushed to the hypertrophic adipocyte more and more, which is going to further precipitate more inflammation and more cardiovascular issues, or this fat will essentially spill over and they will start depositing in the organs. That's what is going to happen. So this is going to spill over, because now your adipocytes can't take up the fat, because already they are having the maximum capacity and they are actively blocking the intake, but the patient stupidly is not able to stop the food intake and is taking more and more unnecessary food, resulting in more and more accumulation of fat in the body. But where this fat will go if the adipocytes are not able to store? It's going to spill over and they're going to go to the organs, especially the liver and the muscle, where the liver is going to be the most important. Once it goes into the liver, because these fats are nothing but free fatty acids, right? So once these free fatty acids are in excess and goes to the liver, they're going to produce more diacylglycerol. Once they're going to produce more diacylglycerol, this is going to activate a protein kinase called protein kinase C epsilon. And this is where the problem is again. This protein kinase C epsilon can actually down-regulate the IRS1 and 2 phosphorylation. Once you are going to down-regulate the IRS1 phosphorylation, this is what we clinically define as insulin resistance. Now we have clear-cut evidence that this adipocyte is going to be the central reason for the development of all the problems in type 2 diabetes mellitus, including insulin resistance and subsequent cardiovascular problems. So that's why we're going to see next adipocyte and its central role in the development of insulin resistance. First of all, you have to know there are two different types of adipocytes. One is the visceral adipocyte, which is going to be the most important. And second one is going to be the subcutaneous adipocyte, or otherwise I can call it as a peripheral adipocyte for that matter. The visceral adipocyte is going to be the most important as far as insulin resistance is concerned. And what is called as visceral adipocyte, those fat that are present in the omentum and mesentery is what we called as visceral fat, and the adipocytes present in those locations are what we refer to as visceral adipocyte. And those that are present in the peripheral subcutaneous areas, including those that are present in the abdomen. So it doesn't mean central obesity means the peripheral subcutaneous abdominal fat. It's about the mesenteric and omental fat we are talking about. That's what we refer to as a central obesity and central abdominal obesity, not the subcutaneous fat that is present in the abdomen. That's okay. And those that are present in the thighs and those that are present in the shoulders, triceps, in those areas, typically you will be calling it as a peripheral fat only. And what is the problem with this visceral fat? Because of the drainage location, because they're going to drain in the portal circulation, where they directly pour their free fatty acid content into the portal circulation, where they will be taken to the liver, resulting in deposition of fat in the liver. So that's where the problem is. That's why visceral fats draining into the portal circulation is really important and makes a lot of sense. And peripheral fat, of course, they are going to drain into the systemic circulation. And considering inflammation, visceral fat is going to produce more inflammatory adipokines compared to the subcutaneous fat, which is going to produce lesser inflammation. Similarly, visceral fat is going to result in reduced adipocyte differentiation compared to that of peripheral fat, which is going to have more adipocyte differentiation. And if they do not differentiate into mature adipocytes properly, they cannot take up the fat, resulting in spilling over the fat into the portal circulation, resulting in more deposition in the liver, resulting in more insulin resistance. That's why this adipocyte differentiation is also very important. And if you remember, I've told you adipocyte differentiation, one of the most important entities is PPAR gamma, and one of the important stimulating agents of PPAR gamma is thiazolinidions. So that's why you give pioglitazone. You can increase the transformation of pre-adipocyte to mature adipocyte. Mature adipocyte is actually good. Hypertrophic adipocyte is the problem. So if you transform pre-adipocyte to mature adipocyte, you can absorb more fat and you can store more fat. So that spilling over will reduce. And at the same time, it will not become hypertrophic adipocyte, because PPAR gamma once again prevents the conversion of mature adipocytes to hypertrophic adipocytes. So your fat will be stored in a very good, healthy mature adipocyte. So reduced inflammation and reduce the spilling over, resulting in reduced fat deposition in the liver. That is the reason why thiazolinidions are resulting in reduced fat deposition in the liver, causing beneficial effects in the setting of non-alcoholic fatty liver disease. You go and see non-alcoholic fatty liver disease, where thiazolinidions is one of the treatment options. And at the same time, increased conversion of this pre-adipocytes, smaller fat adipocytes, to bigger fat adipocytes in the form of mature adipocytes in the setting of thiazolinidions is one of the reasons for development of weight gain also in patients who are receiving thiazolinidions, which is a side effect of thiazolinidions, which we'll be discussing after some time in the subsequent sessions when we are discussing about treatment of type 2 diabetes mellitus. Okay. Similarly, visceral fat is going to produce reduced protective adipokines like adiponectin and leptin, compared to that of the peripheral fat, which is going to produce more protective adipokines like adiponectin and leptin. Visceral fat is more insulin resistant compared to that of the peripheral fat, which is more insulin sensitive, to be precise. And fatty acid release is going to be more from the visceral fat compared to the peripheral fat, because they are more insulin sensitive. That's why insulin can inhibit hormone sensitive lipase. So lipolysis will be little less in the peripheral fat compared to the visceral fat. That's why they are having a reduced free fatty acid release. So there are a lot of differences between visceral fat and the peripheral fat, and the most important being the visceral fat, which is going to be the cornerstone for majority of the problems that are happening in type 2 diabetes mellitus and obesity. So let us consider an adipocyte which is inflamed and it's infiltrated by macrophages, and insulin in the adipocyte acts on the insulin receptor. Insulin receptor should result in phosphorylation of IRS1 and 2, and this will further result in downstream pathways like PI3K-AKT pathway activation. This activation of PI3K-AKT pathway will result in inhibition of a very important enzyme within the adipocyte called as hormone sensitive lipase. We know hormone sensitive lipase is going to convert triglyceride to free fatty acids, and that's what we refer to as lipolysis. And insulin, by inhibiting hormone-sensitive lipase, is a powerful inhibitor of lipolysis from the adipocytes. And hormone-sensitive lipase is very important as far as adipocytes is concerned and not liver or skeletal muscle is concerned, which are also insulin-responsive tissues. And if you talk about an hypertrophic adipocyte, especially the visceral adipocyte, which is loaded with a lot of fat, and definitely this will result in macrophage infiltration by the mechanism I told you previously. Macrophage infiltration resulting in more inflammation, resulting in more production of inflammatory cytokines like tumor necrosis factor alpha and IL-6, which is known to be a powerful blocker of IRS1 and 2 phosphorylation, which can result in reduced PI3K and AKT pathway activation, resulting in reduced inhibition of hormone-sensitive lipase, which means there is more activity of hormone-sensitive lipase, producing more lipolysis and more free fatty acids in the portal circulation, which is what is very important because we are talking about a hypertrophied visceral adipocyte. And of course, one more action of insulin is to take up glucose. Even in adipose tissue, this glucose uptake is really important, especially by the GLUT4 transporter. In the setting of low PI3K AKT4 activity, the GLUT4 transporter will be poorly active, resulting in poor uptake of glucose and subsequently more glucose in the portal circulation. So there's going to be more free fatty acid and more glucose in the portal circulation. That is going to enter the beta cell first, where in the beta cells more glucose and more free fatty acids, of course, is going to result in more insulin release, because glucose is the powerful stimulator of insulin secretion, but free fatty acids and amino acids can also produce insulin from the beta cells. And this is what is going to result in a clinical hyperinsulinemic state. That's how obesity itself can result in hyperinsulinemia. You need not have only insulin resistance. Just obesity itself can result in hyperinsulinemia. At the same time, these free fatty acids and glucose are going to enter the liver as well. But let us first handle the free fatty acids. So in the liver, increased free fatty acids will be definitely converted to diacylglycerol, which will be subsequently converted to triglycerol. Especially in the portal circulation, now after crossing the pancreas, you're not only having high free fatty acids, you're also having high insulin. And this high insulin, of course, in the liver, it's going to become anabolic, and they're going to convert the conversion, and they're going to stimulate the conversion of free fatty acids to diacylglycerol and triglycerol. And of course, this diacylglycerol is going to stimulate the protein kinase C epsilon by the previous mechanism which saw already. They are going to reduce the IRS1 and 2 phosphorylation, which is going to subsequently produce a clinical insulin resistance. And remember the fact that this increased insulin response from the beta cell happens only in the early stages. Slowly over a period of time, this hyperinsulinemic response will vanish because of the persistent hyperglycemia and increased free fatty acids in the portal circulation that can result in lipotoxicity, and chronic glucotoxicity might result in downregulation of the beta cell numbers because of beta cell apoptosis by free radical mediated damage, which I told you previously, which can subsequently result in low insulin production over a period of time. But this is what happens in the early phases at least. And as I told you, the insulin resistance can happen in many areas, but more important as far as liver and skeletal muscle is concerned, apart from the adipose. Liver is one of the worst affected tissues because in the liver, your glucose metabolism should be very, very important. And one of the worst affected metabolism is also glucose metabolism only, where the glucose metabolism will become completely resistant to insulin action. You know what are the effects of insulin on glucose metabolism in the liver? First, they are going to produce increased glycogen by activation of glycogen synthase, and they're going to produce reduced gluconeogenesis by inhibition of the gluconeogenic enzymes like glucose 6-phosphatase, fructose 1,6-bisphosphatase, then we have pyruvate carboxylase. All these are sensitive to insulin, and the insulin is going to inhibit the gluconeogenic hormones. But remember the fact, in the presence of insulin resistance, glycogen production will decrease because, of course, your glycogen synthase enzyme will not become active in the setting of insulin resistance, and gluconeogenesis will increase because your gluconeogenic hormones, in the absence of insulin or in the presence of insulin resistance, it's going to become more active, and they're going to pour a lot of glucose into the blood. Already your liver is containing lot of glucose that is getting poured, because already, as I told you, the visceral adipocytes are not taking up the glucose, resulting in more glucose in the portal circulation. And coupled with that, liver is not utilizing this glucose to produce glycogen. At the same time, they are pouring out more glucose in the form of gluconeogenesis also. Both these things are going to result in hyperglycemia. And if they ask you the most important mechanism of hyperglycemia in the setting of diabetes mellitus, it's always the hepatic gluconeogenesis. And accelerated hepatic gluconeogenesis because of insulin resistance is the most important reason for hyperglycemia in type 2 diabetes mellitus. And it's also the most important reason for hyperglycemia in type 1 diabetes mellitus, but there it's due to insulin deficiency. But accelerated gluconeogenesis is the most important reason. And in the skeletal muscle, same process of insulin resistance can happen, where once again the glucose metabolism will be the one that will be worst affected, where in the skeletal muscle the most important problem is the reduced glucose uptake by the GLUT4 transporters. That will once again contribute to the development of hyperglycemia. And this will subsequently result in the clinical features of diabetes mellitus as well as the complications of diabetes mellitus in patients who are suffering from type 2 diabetes. That's it. And we have not yet discussed about the triacylglycerol's fate. Triacylglycerol in the liver, they are going to produce more VLDL. More VLDL in the periphery, they will be stripped to triglycerides and IDL and subsequently LDL. So in the setting of more triacylglycerol production by the liver, you might result in hypertriglyceridemia, which is one of the quintessential problems with regards to lipid profile in the setting of type 2 diabetes mellitus. And increased LDL because of increased VLDL can result in accelerated atherogenesis as well, which can itself result in micro and macrovascular complications in diabetes. And increased triglycerides pose a major problem again, because this will be a target for another enzyme called capillary lipoprotein lipase. We know this enzyme is under control of insulin, where insulin will stimulate the capillary lipoprotein lipase, because in the setting of type 2 diabetes in the early stage, you are having hyperinsulinic response. And capillary lipoprotein lipase will produce more influx of triglyceride into the adipose tissue. And macrophages try to push the triglyceride out, but insulin, once again, with the help of capillary lipoprotein lipase, they are pushing more triglycerides inside. And these more triglycerides are again pushed out through insulin resistance by the macrophage mediated inflammation and more free fatty acids, and they're entering the liver and they're producing more insulin resistance, more hyperglycemia and more hyperinsulinemic response, and that is producing more triglyceride output from the liver in the form of VLDL, more triglyceride entry into the adipose tissue, more insulin resistance, more inflammation, more hypertrophic adipocytes, and more cardiovascular problems. And this vicious cycle will keep on continuing for on and on and on until and unless you stop something in between. And this is the complicated pathophysiology. And remember the fact that there are differential responses in different areas with regards to insulin resistance. For example, in the skeletal muscle, the most important that will be affected with insulin resistance is the glucose uptake. That will be the most important as far as skeletal muscle is concerned. As far as the liver is concerned, the most important area that will be affected with insulin resistance is the gluconeogenesis. That will be accelerated. And coupled with that, there will be some other problems like reduced glycogen, but that is not that important. And in the adipose, because of insulin resistance, glucose uptake will be affected. At the same time, there will be accelerated lipolysis as well because of reduced activity of hormone sensitive lipase. So reduced glucose uptake, increased gluconeogenesis, and increased lipolysis. So these are the problems with regards to the insulin resistance for that matters. But what are the enzymes that remain sensitive? Enzymes that remain sensitive despite having insulin resistance. Despite insulin resistance. Two enzymes are very, very important. One is acetyl-CoA carboxylase, which helps in converting acetyl-CoA to more fatty acid, and that's the reason why liver is able to produce more VLDL and more triglyceride output. And second enzyme is capillary lipoprotein lipase. These two enzymes retain their sensitivity, and this is going to be another major problem in the setting of type 2 diabetes mellitus that we're going to face. A lot of enzymes are actually resistant, but these two enzymes relatively are sensitive in the setting of insulin resistance, and because of hyperinsulinemia, these enzymes can actually be more stimulated, to be frank. And with regard to the clinical features of type 2 diabetes mellitus, number one, majority of the patients will be having evidence of insulin resistance like acanthosis nigricans, skin tags, PCOS, or they might be having evidence of hyperinsulinism, or they might be having evidence of metabolic syndrome in the investigation parameters as well. And they can be completely asymptomatic. That's very important. That's the role of the screening programs in adults, because over time this diabetes definitely is going to create microvascular and macrovascular complications, and they will be cooking up slowly over a period of time. So they can be detected incidentally. In fact, majority of them are detected incidentally with respect to type 2 diabetes mellitus. Or they can present symptomatically with osmotic symptoms like polyuria and polydipsia because of hyperglycemia. Or they can present with polyphagia as well, because glucose uptake is made by insulin. Majority of the tissues will be starved of glucose without proper action of insulin. So if this is the case in hypothalamus, they will sense this as low glucose within the cell. That means low energy conversion into ATP, which means the hypothalamus will falsely perceive as low energy state in the body and increasing the hunger state, producing polyphagia. And number 5, they can even present with insulinopenic symptoms later in the course of type 2 diabetes, especially late in the course. It takes decades sometimes to get to this insulinopenic stage, where the patient will be presenting with weight loss, cachexia, malnutrition, severe fatigue, and they might be having ketosis, which can even progress to diabetic ketoacidosis in the setting of stressful scenarios. And insulinopenia, of course, will be due to beta cell loss. In type 2 diabetes mellitus, it takes a long time to develop a complete beta cell loss. But remember the fact that at the time of diagnosis of type 2 diabetes mellitus itself, there is an estimated loss of 30 to 50% of the beta cells from the initial value. That's also a very important point to know. And beta cell loss may be due to many reasons. The first reason, of course, is going to be the lipotoxicity and the glucotoxicity, which is going to generate free radicals and which can precipitate development of activation of caspase mechanism and apoptosis subsequently, which we have discussed in the previous video itself. Or it can be due to beta cell exhaustion. Of course, if you are going to work harder against resistance for a longer period of time without rest, you will die over some time. So that's the reason why the beta cells die. And third reason is due to development of a localized form of amyloidosis called as islet cell amyloidosis or a beta cell amyloidosis, which is due to increased accumulation of a substance called pro-IAPP. IAPP stands for islet amyloid polypeptide, which is otherwise referred to as amylin, which has multiple physiological functions like reduced gastric emptying, like that of incretins. IAPP is usually released along with insulin, and it's going to be coming from a substance called pro-IAPP, and it's cleaved into IAPP by a proteolytic step done by a enzyme called proconvertase 2, not proconvertase 1. Because in insulin resistance, there will be increased amount of insulin secreted, there will be increased amount of pro-APP also will be secreted, and if some pro-APP will not be able to get secreted, and if it accumulates within the pancreas, within the beta cells, that will result in a beta cell amyloidosis. Of course, amyloidosis is going to cause apoptosis after some point of time. So one of the other reasons why there is death of beta cells in the setting of type 2 diabetes mellitus. We have been talking a lot about insulin resistance. Is there any way to find out insulin resistance in reality? Or is there any way to quantify this insulin resistance? Answer is yes, you can actually quantify the insulin resistance using certain techniques. And there are some invasive techniques as well as there are some non-invasive techniques to assess and quantify the insulin resistance. Invasive techniques are of course the gold standard, which we typically refer to as something called as euglycemic hyperinsulinemic clamp. But there are some hyperglycemic clamps which are typically used for assessing insulin secretory capacity, hyperglycemic clamps. But hyperinsulinemic clamps, or called as euglycemic hyperinsulinemic clamps, are used for assessing the insulin resistance. That's the gold standard. Let me come back to that. But there are some non-invasive ways to measure the insulin resistance. The typical index is preferred for that quantification of the insulin resistance is the HOMA-IR index. That stands for homeostatic model for assessment of insulin resistance. So that's what we refer to as a HOMA-IR index, and we have a separate HOMA index for beta cell function as well, which I'm not going to discuss in this particular video, but let us see about the HOMA-IR index. HOMA-IR index can be measured using a formula called glucose multiplied by insulin divided by 405. If your glucose unit is milligrams per deciliter. In India and many other Western countries like USA, your glucose will be measured in milligrams per deciliter only, but there are some European countries where glucose will be measured in millimoles per liter. So in that setting, the formula will change. We are going to measure the HOMA-IR index by a formula called glucose multiplied by insulin divided by 22.5. Suppose if you are using glucose in the millimoles per liter index. Remember, insulin is standard. We are going to use only microunits per ml. That's a standard everywhere. So that's not a problem. But you have a separate index called HOMA beta index, which is not actually a test of insulin resistance, but rather a test of beta cell function. That's completely different. So you should not confuse that HOMA beta index with the HOMA-IR index. And what about the euglycemic hyperinsulinemic clamp? The idea is very simple. So I'm going to give a continuous insulin infusion to a patient to maintain the plasma concentration of insulin at a fixed value. Say for example, I want to maintain plasma concentration of insulin at 100 units per ml. Of course, this is going to result in hypoglycemia, but I should not allow the patient to go for hypoglycemia, so that I'll be giving a continuous glucose infusion, probably in the form of dextrose as well. So I should have a target for maintaining glucose. Here the target I'm going to set for, say example, capillary blood glucose at 110 milligrams per deciliter. To maintain this 100 milligrams, maintain this blood glucose level of 110 milligrams per deciliter in the background of a continuous insulin infusion, how much glucose I need? That's what the idea is. I'm going to measure it by using a thing called a glucose infusion rate in milligram per kilogram per minute. So it will be measured in milligram per kilogram per minute. Suppose if my glucose infusion rate is very, very high, what does that mean? Which means insulin is acting good. Insulin is the one that promotes the glucose uptake. There will be too much of consumption of glucose by the cell, so that the blood glucose level falls drastically down in the setting of insulin. And if the insulin is acting very good, so my glucose infusion rate is very, very high. So I need a more glucose to maintain the glucose in the range of 110 milligrams per deciliter. So it indicates insulin sensitivity. Suppose if my glucose infusion rate is very low, which means here the insulin is acting very poorly. That is the reason why cells are not taking up glucose, which means my blood glucose levels are already maintained because the blood cells are not taking up glucose, and I need a very little glucose from outside to maintain the blood glucose in the normal range. So if the glucose infusion rates are low, then it indicates insulin resistance. You can actually exactly quantify how much is the level of resistance based on this method. That's why it is the gold standard. But I'm not going into the exact details because that is beyond the scope of the current discussion. And this graph is going to show how they're going to assess the insulin resistance through the euglycemic hyperinsulinemic clamp, where you can see once they have achieved the steady state. So for say in this example, they are maintaining insulin at 200 microunits per ml, and they are assessing the glucose infusion rate, which means at what glucose infusion the blood glucose is maintained at probably 110 or 150 milligrams per deciliter, depending on your experiment, at that particular insulin level. So that is going to tell you the glucose infusion rate, and which is going to be an indirect reflection of how much glucose is getting uptaken by the cells, and that is going to reflect how much is the insulin sensitivity or how much is the insulin resistance. So that's the gold standard. So anyway, for exams, you have to tell only one thing. Gold standard for assessing insulin resistance is an invasive technique called as euglycemic hyperinsulinemic clamp. Let us discuss some of the biochemical pathways that are deranged in the setting of type 2 diabetes mellitus. We know the worst affected pathway in insulin resistance is the glucose metabolism pathway. First, let us start with glycogen metabolism, where glycogen synthase enzyme, which is the key enzyme in glycogen production, which is highly under hormonal control by insulin, and it's activated by insulin, which will be less active in the setting of insulin resistance, so you're going to produce reduced glycogen. We know why liver is producing glycogen, because there will be high glucose flood after a meal along with insulin, which is a sign of well-fed state. The liver is going to take up this excessive glucose through glucokinase pathway, and they're going to convert that to your glycogen. But in the setting of insulin resistance, the glucokinase enzyme will be less active, so liver cannot take up sufficient glucose, and at the same time they will not be able to convert this glucose into glycogen, resulting in spilling over of the glucose into the blood, resulting in hyperglycemia. That is because of poor utilization of the glucose by the liver. And apart from that, as I told you before, the most important reason for hyperglycemia and type 2 diabetes as well as type 1 diabetes is the accelerated gluconeogenesis. In the setting of insulin resistance, there will be too much activity of the gluconeogenic enzymes like glucose 6-phosphatase, fructose 1,6-bisphosphatase, as well as pyruvate carboxylase. These are the key enzymes for gluconeogenesis, and they are highly under the control of insulin, which tries to inactivate these enzymes. But under the influence of insulin resistance, these enzymes will become highly active, resulting in more conversion of gluconeogenic substrates to glucose, producing more pouring of glucose into the blood, resulting in hyperglycemia, especially in the fasting state, producing fasting hyperglycemia. And gluconeogenesis that is accelerated is the most important reason for hyperglycemia in the setting of any diabetes, including type 2 diabetes mellitus. And let's come to the fatty acid metabolism. We know acetyl-CoA carboxylase retains its sensitivity even in the setting of insulin resistance, and even a small amount of insulin is enough to produce free fatty acids in the liver, and at the same time small amount of insulin is enough to suck this acetyl-CoA towards the free fatty acid pathway rather than pushing towards the ketogenesis, which means in type 2 diabetes mellitus, because there is hyperinsulinemia in the first place and you still have some amount of insulin, that will definitely prevent the ketogenesis, and ketogenesis will not happen. Rather, because acetyl-CoA carboxylase retains its sensitivity, more free fatty acids will be produced from acetyl-CoA and more triacylglycerol will be produced, which will be obviously pushed towards VLDL pathway in the liver. We are talking about the liver now. And this VLDL, under the influence of capillary lipoprotein lipase, as I told you, this also retains sensitivity. Even in the setting of insulin resistance, they will be sensitive. And that's going to produce more triglycerides within the adipose tissue, as I told you before. And of course, this triglycerides will be pushed back to free fatty acids through lipolysis, because there is another enzyme that is hormone sensitive lipase, which will be too much active in the setting of insulin resistance, because this hormone is resistant to insulin now. And they are going to produce lipolysis, and they are going to increase the level of free fatty acids. As I told you before, once you produce free fatty acids in the blood, not in the liver, we are talking about free fatty acids in the blood, that's an unregulated pathway. Once they are produced, automatically they will enter the beta oxidation pathway, and they're going to produce more acetyl-CoA. And this excessive acetyl-CoA, of course, in the liver is going to get sucked into the acetyl-CoA carboxylase pathway, producing malonyl-CoA and then subsequently free fatty acid, that is palmitoyl-CoA, which is going to produce more triacylglycerol, more VLDL, more triglyceride in the adipose tissue, and more free fatty acid, more acetyl-CoA in the liver, and more free fatty acid in the liver. And subsequently, this cycle will keep on continuing, and liver is going to produce more VLDL, and adipose tissue is going to produce more lipolysis. Subsequently, are going to have excessive free fatty acids in the liver as well as in the peripheral blood. That's a characteristic feature of a type 2 diabetes mellitus. And as I told you before, this excessive VLDL is a problem because they don't only produce hypertriglyceridemia and excessive triglycerides in the adipose tissue, they are also going to produce excessive LDL. Because once you take the triglyceride component out of VLDL, you are going to result in IDL and subsequently LDL only. So that can result in accelerated atherogenesis as well. And one more important fact that you have to know is the thing that this excessive acetyl-CoA is an allosteric activator of pyruvate carboxylase, which can subsequently activate the gluconeogenesis, producing more and more glucose and resulting more hyperglycemia. So there are a lot of biochemical pathways that are deranged in the setting of type 2 diabetes mellitus, and the most important reason for hyperglycemia is your accelerated gluconeogenesis, then followed by reduced glucose uptake by liver as well as by skeletal muscle and adipose, and third thing is the reduced glycogen production. So all these things are playing together to produce hyperglycemia. At the same time, type 2 diabetes mellitus is a condition where you're going to have excessive VLDL production and triglyceride production subsequently, and there will be hypertriglyceridemia and there will be high LDL levels at the same time, resulting in increased atherogenesis, and ketogenesis will not happen because there will be hyperinsulinemia, and acetyl-CoA carboxylase is sensitive. Because of that, it takes all the acetyl-CoA towards the fatty acid synthesis pathway rather than pushing it towards the ketogenesis pathway. So ketone production will not happen like type 1 diabetes mellitus. And these are the metabolic pathways that are deranged in the setting of type 2 diabetes mellitus. And let's complete our discussion and this particular session with understanding about gestational diabetes mellitus. The pathophysiology is important. Before that, we need to understand the physiology of how the glucose transport is happening and subsequently fetal growth is happening. So we have to know that glucose transport across the placenta is a passive phenomenon working by concentration gradient, which is done by GLUT1 and 3 transporters. How it works by concentration gradient? For example, if you have 100 molecules of glucose in the maternal side, there will be 80 molecules of glucose on the fetal side, and that's how it works by concentration gradient, because solutes in this particular example is moved from a region of higher concentration to a region of lower concentration just by concentration gradient. And why this glucose is important in the fetus? Because this glucose is going to stimulate the fetal pancreas to produce more insulin. At the same time, it suppresses the glucagon production to an extent, and this will result in increased insulin and glucagon ratio that is going to promote fetal growth. So, and to have a sufficient fetal growth, which is accelerated during the second and the third trimester, you need to have more glucose on the fetal side. To produce more glucose on the fetal side, the mother has to produce more glucose as well. How the mother produces more glucose? By a lot of principles. The first thing is done by the fetus itself. It produces a trap by producing something called a human placental lactogen. During the second and the third trimester, this is going to produce a sort of insulin resistance by reducing the IRS1 and 2 phosphorylations. As I told you before, if you reduce the IRS1 and 2 phosphorylation, it will manifest as reduced insulin action, which is nothing but insulin resistance. Once you develop a sort of insulin resistance, you will result in increased insulin production in the mother, and that's important because that is the one that is responsible for the weight gain in the mother as well. Not only insulin resistance, at the same time cortisol production, progesterone, all these things act synchronously to produce weight gain in the mother, but insulin resistance is also one major reason for weight gain in the mother. And this insulin resistance will also tend to produce a slightly increased glucose, even though not in the diabetic or hyperglycemic range. They tend to produce excessive glucose. And this slight increase in the glucose is important because by concentration gradient, excessive glucose on the maternal side will be moving more towards the fetal side, which means that slightly more glucose that is coming to the fetus will increase the insulin production, which subsequently manifests as increased fetal growth during the second and the third trimester. So that is the reason why first trimester of pregnancy is often supposed to be insulin sensitive, which means they are having more insulin sensitivity during the first trimester, whereas in the second and the third trimester, the mother tends to go for insulin resistance. In normal pregnancy, generally this resistance tends to be subtle and not manifest as a frank diabetes, but in the setting of pre-existing insulin resistance, this subtle insulin resistance can become an overt insulin resistance and they can develop frank hyperglycemia. And this increase in glucose doesn't only come from the insulin resistance generated by human placental lactogen. This can also be due to excessive cortisol that is produced during the second and the third trimester by the mother itself, and at the same time there is progesterone that can also cause a slight amount of insulin resistance, which increase in the second and third trimester once again. Now, as I told you, what causes insulin resistance? If all these things are a physiological phenomenon, then what causes this kind of gestational diabetes mellitus? It's the pre-existing problem in the mother, especially in the setting of pre-existing subtle insulin resistance, which becomes overt in the setting of gestational diabetes. So let me write a mother who is having no pre-existing insulin resistance will not develop any gestational diabetes mellitus. Even in the setting of human placental lactogen, even in the setting of cortisol, even in the setting of progesterone, they are not going to develop any gestational diabetes mellitus. But mothers who are having pre-existing insulin resistance or risk factors for insulin resistance, like already obesity is there, already there is some evidence of insulin resistance like acanthosis nigricans, already these patients are smoking, so there is some risk factors there for pre-existing insulin resistance. And these mothers, if they get exposed to this cortisol, progesterone, and human placental lactogen, there is a possibility that this subtle and covert insulin resistance might become an overt insulin resistance, and this kind of overt insulin resistance resulting in impaired glucose tolerance and impaired fasting glucose is what we refer to as a gestational diabetes mellitus. So what is the problem in patients with gestational diabetes mellitus? Already HPL and many other factors in pregnancy is going to induce insulin resistance. Coupled with already these mothers are having insulin resistance, and HPL is going to produce more insulin resistance, resulting in too much of insulin production in the mother. And the mother, one of the important signs of development of gestational diabetes mellitus is too much weight gain in the mother. Excessive weight gain is one of the signs of gestational diabetes mellitus as well. And the mother is going to produce too much glucose as well. And this too much glucose is the one that is manifesting as impaired fasting glucose and impaired glucose tolerance. And too much glucose traveling across the placenta into the fetus will produce too much insulin in the fetus, more than what is required, and too much insulin glucagon ratio, and too much fetal growth, which is going to manifest as macrosomia and a big baby. This is how you're going to result in a gestational diabetes mellitus. But pre-gestational diabetes mellitus has a completely different pathophysiology, which I'm not going to discuss in this particular video. With this, I'm going to stop the discussion in this particular session. In the next session, we'll be discussing on the remaining aspects of the classification, the types of diabetes, especially the monogenic forms of diabetes and the other types of diabetes with respect to the insulin action, which is really, really important. So till that, stay tuned. Let us see in the next video. Bye-bye.